Good day, everyone. It's good to see you again. In this session, we will continue our discussion on endocrine and metabolic geriatric clinical care. Before that, let's revisit what we talked about during the last session. We described normal age-related endocrine and metabolic changes in older adults. We also explained how aging reduces metabolic reserve and stress response. By the end of this session, the learner will be able to 1. Identify geriatric-specific risks in diabetes management and recognize hypoglycemia and hyperglycemia in older adults. 2. Recognize atypical endocrine disorders and prevent metabolic decline using geriatric reasoning. We will continue by seeing what makes diabetes unstable in older adults. Let's look at diabetes in older adults. The management of diabetes in older adults prioritizes safety rather than strict glycemic control. Older adults are at increased risk of hypoglycemia due to impaired counter-regulatory responses, renal impairment affecting drug clearance, irregular nutritional intake, and cognitive impairment that may affect adherence. Clinical care should emphasize individualized targets, avoidance of hypoglycemia, and simplified regimens to preserve function. Let's continue with another point, hypoglycemia. This often lacks classic adrenergic warning symptoms. It may present as confusion or delirium, weakness or fatigue, unexplained falls or syncope, or sudden behavioral change. This increases delayed recognition and risk of arrhythmias, falls, cognitive injury, and mortality. Now let's discuss hyperglycemia and dehydration. Hyperglycemia in older adults is frequently closely linked to dehydration. Reduced thirst perception and acute illness such as infection and medication effects contribute to inadequate fluid intake. Clinical manifestations may include delirium, generalized weakness, and functional decline, often occurring before classic symptoms such as polyuria or polydipsia become evident. Next is how we can prevent metabolic deterioration. One of the endocrine disorders is thyroid disorders. Thyroid disease in older adults commonly presents without classic textbook symptoms. Hypothyroidism may manifest as fatigue, depression, cognitive slowing, or reduced mobility rather than cold intolerance or weight gain. Hyperthyroidism may present atypically with weight loss, atrial fibrillation, weakness, or worsening osteoporosis rather than overt tremor or heat intolerance. These atypical presentations contribute to underdiagnosis and delayed treatment. Another disorder is adrenal dysfunction and steroid effects. Adrenal insufficiency in older adults often presents subtly and may only become apparent during physiological stress. Clinical features may include fatigue, hypotension, and confusion, particularly during acute illness or surgery. Chronic steroid use in older adults is associated with significant metabolic complications, including hyperglycemia, muscle wasting, osteoporosis, and increased infection risk. Let's look at malnutrition and sarcopenia. Malnutrition is a pathological condition in older adults and should never be considered a normal consequence of aging. Contributing factors include poor appetite, depression, or social isolation, and chronic disease. The consequences of malnutrition include sarcopenia, frailty, impaired immune function, poor wound healing, and increased mortality. Now, we will look at the clinical reasoning focus. Advanced practitioners should routinely assess what has changed from the patient's baseline. Consider whether symptoms may be metabolic or medication-related. Evaluate adequacy of nutritional intake, and anticipate the risk if the condition worsens overnight. In conclusion, endocrine and metabolic disorders in older adults often present atypically with symptoms like confusion, weakness, falls, and functional decline rather than classic signs, leading to delayed recognition. We've come to the end of this session. Thanks for watching. See you in the next session.